Good afternoon. From Orthopedics Trauma Center, today we are going to present our experience with treating a malady whose importance has not yet sunk in. As the population ages, the orthopedic problems among the elderly are on the rise, and it is, according to one of the estimates, 75% of the expenses on people who are older than 75 years of age are on orthopedic conditions. Moreover, one of the uh, serious problems which the elderly get is fragility fractures, particularly the hip fracture. And it is said that we come into the world through the brim of the pelvis and go out through the neck of the femur. To emphasize that this is often a terminal event. Now, when the patient gets a hip fracture, often the attendants don't realize the gravity or the seriousness of the situation. And that is why it is very important that we expediently treat this condition in addition to explaining to the attendants the seriousness. So we are going to present today the international perspective and how we have incorporated those in our practice in trauma center. And I would like to invite Dr. Nishank Mehta, set the ball rolling, give you our experiences with dealing with the hip fracture in elderly at JPNATC Apex Trauma Center.
Uh, Thank you, sir, and warm welcome to all of you. Professor Malhotra's presence at the helm of affairs at the Trauma Center has been the main contributor behind our achievements in this difficult problem. So, in the next 45 minutes, we'll be showcasing our efforts to put our elderly back on their feet again after hip fractures. So, have you ever wondered why our superheroes are always young? Is it because our imagination also, in some ways, mirrors our apprehensions and fears? In the sense that we have all seen our elderly go tumble down the downward spiral after a fragility fracture of the hip. What we want to emphasize is that in modern orthopedic practice and with a multidisciplinary approach to treating hip fractures, this need not be the case. And we can, in fact, have superheroes with gray hair also. So, we have been using this word almost on a daily basis in the last year and a half. The word pandemic has three main components. One, a widespread occurrence. Two, it occurs over a wide geographic area. And three, it affects a significant proportion of the population. Now, if we overlook the term infectious, you will find that this definition perfectly fits the situation of hip fractures in the world as it is today as well. So, what we are living through right now in the form of COVID-19 is actually a pandemic within a protracted pandemic of hip fractures, which which can be attributed to an aging population and increasing life expectancy. So, this is a table from the Global Burden of Disease Study 2019. What you can see here are some very telling figures. You can see that the percentage of patients, the incidence of hip fractures has undergone a 92.7% increase between 1990 and 2019, during which time the population of the world grew only at 30%. So this growth of population by 30% actually matches the growth in rate of other fractures, but the growth in hip fractures far outpaces this. And when you compare it to when you compare the years lived with disability for fractures of skull and fractures of vertebral column, which are considered the most ominous of all fractures, you will find that this is only a fraction of the years lived with disability with hip fractures due to the sheer burden of the problem. So again, the numbers stack up and speak for themselves in this slide, as we can see that 30% of people over the age of 65 fall every year, and 10% of these falls result in a hip fracture. In fact, 1 in every 3 women and 1 in every 5 men aged more than 80 will suffer an osteoporotic hip fracture. The facts and figures are even darker for a country like India, where there is no reliable data on the incidence and prevalence of osteoporosis, since there is no hip fracture registry or national database. We right now have a 10% of population aged more than 50, but this is projected to be account for 1/3 of our population in 2050. Again, 80% of our urban population is vitamin D deficient, and hip fractures occur a decade earlier compared to Western population according to studies. Much closer home, this is a study which has been done in 16,000 men and women aged more than 50 years from Delhi. And what you can see here is that 1/4 of males above the age of 70 and 2/3 of women above the age of 70 are in the range of osteoporosis as defined by WHO. So countries in developed countries in US and Europe are right now hit by what we can call as a silver tsunami due to the aging population. And there is nothing actually to rejoice in the fact that India reports one of the lowest incidence of hip fractures, because this is likely to be attributed to our young population and faulty data reporting, and these numbers are only going to rise in the coming decades. The disability brought about by hip fractures also paint a rather grim picture. 40% patients with hip fractures require assistance a year later. 1/3 of these patients are dependent or are admitted in a nursing home in the year following hip fracture. The total number of hospital admissions due to hip fracture outnumber those due to diabetes, hypertension, and breast cancer put together. The mortality is a staggering 20% at 1 year. And to top it all, there is a 2.5 times risk of a subsequent fragility fracture after sustaining one hip fracture. The economic repercussions are also quite severe. The health and social care costs at 12 months are a staggering $43,000, which is more than what an average consultant at AIIMS earns during this period. The direct cost of each hip fracture is much less in India, where the treatment is cheaper, but due to the sheer numbers involved, this is still a very tremendous burden on our already fragile economy. This is data that we are reporting from JPNATC over the last 5 years. We have seen a total of 1,464 patients with hip fractures over the last 5 years. And out of this, 64%, that is 941 patients, were aged more than 60. Per-trochanteric fractures were observed in 78% of patients as compared to neck femur fractures, which was seen in 22% of patients. Majority of patients reported fall as the most common mode of injury, while the rest of the patients attributed their injuries to road traffic accidents. The percentage of patients who had hip fracture after a fall increases when you narrow it down to patients aged less than 60 years and accounts for 85% of total. Older patients and female patients have a higher proportion of falls. This is one very worrying metric as far as our country is concerned. As we can see here, around 1/3 of the patients aged more than 60 years had a delayed presentation of more than 24 hours from the time of injury. And in fact, 19% patients present after 48 hours, which as per international recommendations is the golden window within which a hip fracture should be operated from the time of injury. However, this is an encouraging metric that we want to share. Over the last 5 years, we have been able to fast track the surgery, and the percentage of patients operated within 48 hours has improved from 62% in 2017 to around 90% in 2021. Again, the median length of hospital stay has been kept down to under 3 days, and most patients with a hip fracture operated at trauma center have a complication-free course in the hospital. Unfortunately, we don't have an exhaustive data on mortality rates, but this data has been gleaned from a prospective cohort of patients which were a part of a postgraduate student's thesis done in 2019. So as you can see here, in a sample size of around 220 patients, the in-hospital mortality was 3% and the one-year mortality was 19%, figures that roughly match the statistics reported from Western population. COVID-19 has severely dented the care of non-COVID patients, and patients with hip fractures are no exception. There was a total decrease of 12% seen in the number of orthopedic patients between April to June 2019 and April to June 2020, when a strict lockdown was in force. This fall in incidence was even more drastic when hip fractures were considered. As far as management of this problem is concerned, non-operative management is almost obsolete as far as modern orthopedic practice is concerned, due to the high mortality and serious functional loss that this entails, which means that surgical treatment is the standard of care. There are several unique challenges in treating India's elderly population. First, it arises because of the poor pre-injury mobility due to sarcopenia and frailty, a poor bone quality due to underlying osteoporosis, unrecognized medical conditions. It is not uncommon for us to see patients who are not in fact a known case of diabetes mellitus reporting with blood sugars in the range of 400, and they have to be started on insulin infusions to enable us to operate upon them. There is also very high attrition to follow-up, and many of these poor patients are unable to bear the cost of treatment. These patients usually present to emergency department with low energy isolated injuries. Like we reported earlier, almost 1/5 of these patients present outside the golden surgical window of 48 hours after the time of injury. The priorities for us in emergency department are a prompt and early diagnosis followed by an early admission, pain alleviation by means of applying traction or use of boot and bar splints, and the use of ultrasound guided nerve blocks in the emergency department itself. The important thing here is also to bring the patients relative to speed regarding the prognosis of this grave condition. Much like the commonly used term heart attack, the term hip attack has been used to describe the expedient way in which these fractures must be dealt with. 48 hours is the golden period which has been reported by authorities in America and Britain. Surgery within 48 hours reduces the 30-day postoperative mortality rate, positively affects the long-term functional outcomes, and reduces the length of hospital stay. It is important to consider fragility hip fracture as a symptom of an underlying disease rather than a disease in itself. The golden principle to follow here is don't just fix, you have to fix and treat the underlying disease. And this basically involves a multidisciplinary management, and we will see experts from each of these disciplines share their perspectives in the treatment of these fractures. I now call upon Dr. Mahindran, a senior resident in anesthesia, to talk about the anesthetic management for hip fracture repair.
Thank you, Dr. Nishank. So in the next subsequent few slides, I'll be discussing our approach towards the anesthetic management of hip fracture repair. So the aims of anesthetic management basically depend upon four primary principles, that is prehabilitation, remobilization, re-enablement, and rehabilitation. So prehabilitation is preoperative optimization that includes adequate analgesia, fluid resuscitation, and managing of reversible medical conditions in the preoperative period. Remobilization is considered as a key performance indicator, and it denotes mobilization of the patient on the day of surgery or in the immediate postoperative period. Pain, hypertension, delirium, anemia are some of the factors that can actually hamper remobilization. Re-enablement is ability of the patient to carry out his day-to-day activities within 3 to 5 days of the surgery. So activity activities of that patient could be hampered because of pain, hypotension, bladder, bowel, and cognitive issues. And finally, rehabilitation. This can be early rehabilitation of the patient can be achieved by proper perioperative analgesia, because poor perioperative pain control can lead to chronic pain and analgesic abuse. So as we can see that pain can lead to increased post-operative delirium, which can in turn contribute to much more pain and chronic pain. So as such, proper perioperative analgesia helps us in breaking this vicious cycle. So the challenges that we face in anesthetic management of geriatric patients who majorly present to us with hip fractures are that there are some comorbidities and a multitude of other factors that these patients present with, out of which hypertension is the most common. Around 50 to 60% patients present with hypertension, followed by diabetes mellitus around 20 to 30%, and other patients can present with coronary artery disease around 15%, followed by frailty, and there is difficulty in positioning for these patients for neuraxial blockade. There are certain areas of controversies in anesthetic management, and these are the mode of anesthesia and surgical delay, blood management and transfusion threshold, perioperative and preoperative echocardiography, and management of anticoagulants and antiplatelet agents. Prehabilitation in our institute is basically carried out, starts with analgesia in the emergency department, where on arrival, all the patients of hip fracture, they receive ultrasound guided fascia iliaca block. They are then subjected to risk stratification by taking into consideration the non-modifiable risk factors and additional factors such as fracture, surgery, and anesthesia. Preoperative echocardiography was previously practiced for many patients, but a recent guideline given by the Association of Anesthetists of Great Britain and Ireland have stated that echocardiography is only indicated in those patients in which there is incidence of atrial fibrillation with a fast ventricular rate of more than 120 beats per minute, or patients who have mechanical heart valves with a recent deterioration in their clinical conditions. In agreement to this, a study carried out in our institute found that echocardiography delayed surgery without a significant change in cardiac medication or anesthesia technique. So currently, surgery is delayed only if the benefits of additional medical treatment outweigh the risks of delaying surgery. Another point of contention is the management of anticoagulants and antiplatelets. So patients who have been recently started on anticoagulants and who are on dual antiplatelet therapy, those patients are subjected to a risk versus benefit assessment. So we assess the patient and see whether the risk for abrupt cessation of medication and a delay to surgery outweighs surgical site bleeding or incidence of vertebral canal hematoma. So our management basically is tailored depending upon the patient profile. So this table basically denotes the journey over 5 years where patients have been treated within 48 hours, which has gone from 63% in 2017 to 90% in 2021. And this has basically been possible because of our adherence to international guidelines that have been recommended. That age-appropriate dose of anesthetic agent is administered with supplemental nerve block and careful management of intraoperative blood pressure. Anesthetic techniques have also been a field of controversy, and a recent meta-analysis in 2019 has stated that as such there is no difference in the 30-day mortality between regional and general anesthesia, but there is an increased incidence of in-hospital readmissions, in-hospital mortality, as well as post-operative delirium in those patients who have received general anesthesia. So our approach towards the technique is that neuraxial techniques with nerve blocks are preferred over general anesthesia. Positioning is facilitated by ultrasound-guided femoral, fascia iliaca, and pericapsular nerve block. Titrated and low drug doses are given in neuraxial anesthesia in high-risk patients. so that hemodynamic fluctuations are minimized. Also, complicated intratrochanteric fractures requiring hemiarthroplasties, we place epidural catheters to aid in early remobilization and to help in pain management in the perioperative period. So these are the images of some of the blocks that we practice in the perioperative period: the femoral nerve block, fascia iliaca block, and the PENG block. Intraoperatively, our goal is to manage these patients depending upon their physiology. So since these are geriatric patients, mostly they present from the geriatric age group, our goal is to restrict our intraoperative fluid therapy, and adequate temperature control is maintained. And also in high-risk patients, we use intraarterial blood pressure monitoring for a beat-to-beat analysis. Postoperative analgesia is managed by our acute pain services teams, who take daily morning and evening pain rounds. And the mode of analgesia is either a continuous epidural infusion of dilute local anesthetic, or a patient-controlled epidural analgesia, or 12-hourly epidural morphine boluses. Apart from this, our teams also assess the patients routinely for any acute perioperative physiological derangements such as dyselectrolytemia or postoperative hypotension. And all these conditions are managed to ensure early mobilization and rehabilitation. So to summarize, the hip anesthesia protocol in the trauma center takes care of preoperative optimization by ensuring adequate analgesia, identifying and treating reversible comorbidities, and determining appropriate level of postoperative care in the preoperative period. So currently we have been successful in achieving around 90% of patients being operated within 48 hours, which we aim to expedite to around 24 to 36 hours of admission. Intraoperatively, we give lower dose of spinal anesthesia, and the anesthesia technique is tailored to the patient profile. We ensure administration of antibiotics and ensure normothermia, strict blood pressure control, and vigilance regarding bone cement implantation syndrome in case it occurs, and its subsequent management. Postoperatively, we reconsider the appropriate level of postoperative care to ensure remobilization, re-enablement, and rehabilitation. And continuous audit is implemented, and quality improvement meetings are also held. Following the same approach, there are currently 2 research projects that we're undertaking. The first project deals with a comparison between PENG block and fascia iliaca block, which for positioning of neuraxial anesthesia, and the second one is a continuous PENG block versus fascia iliaca block for intraoperative anesthesia and perioperative analgesia. Thank you.
I now invite Dr. Yamini, who is a senior resident in geriatric medicine, to talk about the perioperative care from a geriatrician's perspective.
Good afternoon, everyone. I'll be talking about an overview of orthogeriatrics and how it benefits the patient outcome in the upcoming slides. So what is orthogeriatrics? It is a medical surgical model which brings together multidisciplinary health professionals from trauma, orthopedics, and geriatric medicine to treat and prevent future fractures and restore functionality and quality of life. The main benefits are recovery of function, reduced length of hospital stay, reduced waiting time to surgery, fewer surgical and medical complications, and improved survival. It basically focuses upon interprofessional multidisciplinary team approach, which includes an orthopedic surgeon, an orthogeriatrician, an anesthetist, a nurse, a physiotherapist, an occupational therapist, and a dietitian. Out of various types of orthogeriatric models of care, in the pre-COVID times, we used to follow the orthogeriatric liaison model of care, in which patients admitted under orthopedic team and regular geriatrician review was held on the orthopedic ward with multidisciplinary input on patient care. So coming to the preoperative issues, the main things that should be focused upon are pain management via analgesics, opioids, and nerve blocks, anticoagulation optimization. Aspirin may be continued without any bridging therapy. NOACs should be stopped 24 hours before surgery. No bridging therapy is needed. In case of warfarin, it should be stopped immediately and bridging therapy should be given, which should be stopped 24 hours before surgery. The volume depletion and electrolyte imbalances should be addressed, and comorbidities should be optimized, like diabetes, hypertension, heart failure, acute chest infection, and exacerbation of chronic chest conditions. Coming to the geriatric syndromes, the main syndromes that should be focused upon are cognitive impairment, depression, baseline activities of daily living, frailty and sarcopenia, sensory impairment, urinary incontinence, pressure ulcers, malnutrition, and delirium. This table is from a study conducted by our department. This is an unpublished study yet. It was conducted by Baburao et al. In Fragility Clinic, which shows 10-year, this table shows 10-year probability of major osteoporotic fracture and hip fracture with reference to major geriatric syndromes. As you can see in this table, depression, fall within a year, impaired activities of daily living, and frailty is significantly associated with hip fracture and most major osteoporotic fractures. Now comes the surgical dilemma. Ideally, hip fracture surgery should be performed within 24 to 48 hours of admission, and it should be delayed only if the patient is experiencing unstable coronary syndrome, decompensated heart failure, significant arrhythmia, severe valvular heart disease, or sepsis. The most common peri and post-operative complications that the patient experiences are cardiac, followed by pulmonary, like atelectasis or aspiration, renal, like acute tubular necrosis, and infectious complications, either surgical site or healthcare associated infections. The post-operative challenges, to address them, ideally, we should advise early mobilization to improve the functional impairment, to prevent delirium, sensory and mobility enhancement, cognitive stimulation exercises, sleep-wake hygiene, and pain control should be addressed. Prevent breath sores. Frequent repositioning should be performed every 2 hourly. Patients should be advised for early mobilization and weight bearing, and air mattresses should be given. The bladder catheter should be removed within 24 hours of surgery. For infection prophylaxis, first or second generation cephalosporins may be used. For nutritional supplementation, 20 grams protein with 800 milligrams of calcium is recommended daily. For anemia, a blood transfusion threshold of no more than 8 is recommended. Now talking about the venous thromboembolism, ACCP estimates the risk of VTE to be high, that is 4.3% in first 5 weeks after hip fracture without prophylaxis. So the prophylaxis is recommended at least 10 to 14 days and up to 35 days. And the candidates are low molecular weight heparin or unfractionated heparin, vitamin K antagonist, fondaparinux, or aspirin. According to NICE guidelines, aspirin is not recommended as a single pharmacological agent for VT prophylaxis. This is another study from our department conducted by Sumitabh et al. In this table shows association of frailty with post-operative complications. As you can see, frailty is significantly associated with hyponatremia, delirium, acute kidney injury, and post-operative infections. Therefore, it should be managed accordingly. In terms of rehabilitation and discharge planning, lastly, multidisciplinary assessment of ongoing health and functional and social needs should be done. Liaison or referral to outpatient rehabilitation or medical and social services should be performed. Commencement of treatment for secondary prevention of fragility fractures based on national or local guidelines like bisphosphonates, raloxifene, teriparatide, or denosumab should be initiated. Communication of ongoing medical needs to general practitioner should be performed. Thank you. Now I hand over the reins to orthopedics department to talk about surgical management.
Thank you, Dr. Yamini, and thanks to Department of Anesthesia and Geriatric Medicine for helping us so much in management of these patients. As already explained by Dr. Yamini, this is not just orthogeriatric care, but it is a multidisciplinary care. And I'm thankful to my colleagues and seniors in anesthesia, critical care, are also here to support us in this presentation. And it is not just these departments, but the Department of Emergency Medicine, cardiology, endocrinology, the physiotherapists, the nurses, and the dietitians who help us a lot in the management of these patients. And let's not forget the nurses who take care of these patients on a day-to-day basis and help them getting up and about. No matter how good a surgery we do, how early we do it, but the aim of the surgery is to get these patients up and moving, get them to their normal diet, and get them to a normal lifestyle that they had before this fall. And this is a team management that helps us do this. So, like Dr. Nishank has already discussed, the two major types of hip fractures that we have are either intracapsular fracture, which is essentially a neck femur fracture, or the extracapsular fractures, which are mostly the intertrochanteric fractures with subtrochanteric extension, with or without the subtrochanteric extension. Now, the neck femur has precarious vascularity, not only in the old patients, but also in the young patients. And even in a younger patient, the neck femur patients do not have a really good prognosis, and there is always a challenge in getting union in these patients. And that is something that we don't want to test in these elderly patients. So the aim of surgery in a neck femur patient, in an elderly patient, is not to try to get union in these patients, but to get the patients up and about, moving, putting full weight, and getting back to their original self as soon as possible. So the aim of treatment in neck femur fractures is not just to get anatomic reduction and fixation when these patients are young, but in these elderly patients, we mostly rely on arthroplasty, which may be in terms of a total hip replacement or a bipolar hip replacement, depending upon the characteristics of the patient. But the aim is to get them moving. While in the case of intertrochanteric fractures, these are more fractures which have higher vascularity, so they do not need a replacement, and they can be done away with the internal fixation. This may be done in in way of a sliding hip screw or a nail. Most recent literature suggests that DHS is as good as nails for stable fractures, but when it comes to unstable fractures and the newer fracture patterns, intramedullary nails is the key in the management of these patients. Now, over a period of years, only in the last 10 years, within my experience at Trauma Center AIIMS, I have seen the type of these fractures go from one end of the spectrum to the other. Now, it is very odd to get a fracture with a normal fracture pattern or a stable fracture pattern. Most of these fractures have a very different kind of a fracture pattern, and many of these fracture types are not even described 5 years from now. And all these fractures, the moment we see unstable fracture in an intertroch, we think of nailing, because this is something that can get these patients up and moving at the earliest with the biomechanical advantages of a nail over a plate. Now, in these elderly patients, we as surgeons don't have to be less totalitarian. We have to look at the patient in a holistic, multidisciplinary approach. And the aim, I will stress it again, the aim of operating upon these patients is to get them moving as early as possible to a level which they were doing just before the fracture, or maybe sometimes even better. So many of these patients have hip arthritis to start off with. And when they do get a fracture and we do a replacement in these patients, even the preoperative pain that they had because of the hip arthritis goes away, and they sometimes have a better gait than before after fixation of these fractures. And we need to decrease the secondary complications to a minimal possible extent. Obviously, the challenges that stand in our patient population is osteoporotic bones, sarcopenia, the difficult rehab, and the throw fracture healing. But that is where the multidisciplinary approach and the help of all the other departments come into place to help us achieve this. With everything that the anesthesia department and the geriatric department does, the job of operating upon these patients becomes really easy. Everyone working as a team, knowing their limitations as well as their strengths, we are able to take these patients up very soon, early for surgery now. And the aim that we do is to operate the patient in the morning and make the patient mobilized full weight bearing using a walker by evening, if not the next day morning. So now when do we do a total hip arthroplasty in neck femur fractures? So if we think within these elderly subset of patients, the patients are relatively healthier, they have lesser cognitive impairment, and they were independently mobilizing before a fall. We have a subset of patients who are very active even though they are old. These are the patients who are a candidate for a total hip replacement. While patients who had a lot of comorbidities to start off with, who had a lot of cognitive impairment and who had limitations in ambulation, or who were only mobilizing within these confines of the home, these are the patients that we select for hemiarthroplasty. As regards intertroch fracture, I've already discussed that if they are stable, then a sliding hip screw is as good as a nail. But when it comes to any odd fracture pattern in an intertroch or a subtroch extension, or with the newer variants of these unstable fractures, then nail is the key. We try to nail these patients as early as possible, and with the immense load of patients and the support from the department, the whole team works in a manner that most of these surgeries can be completed in less than 10 minutes, and most of the neck femurs can be replaced in 15 to 20 minutes of time. So it is a really short lasting surgery which done early in the rehab course and early mobilization can lead to great results. So now in 1996, the nails that I'm talking about, the first nail came out, proximal femoral nail, which is now the mainstay of treatment, came out in 1996. And it is not the same nail that we use now. Now new generations of these nails have come up, and we are now using the 4th or 5th generation of these intramedullary nails, which has helped us mobilize these patients very early now. So, and they are very useful in osteoporotic bones, and they have a distinct biomechanical advantage in being intramedullary implants. They do have some drawbacks, which is anterior thigh pain at the impingement of the nail in the thigh, or sometimes they can cause a back out or cut out of the screw, which has been improved in the newer nailing systems. All surgeries tend to have some failures. These surgeries also have some failures, but over a period of time, the results have improved and improved. We saw this problem with the anterior cortical impingement in these nails. So in collaboration with IIT, we did this study last year involving 150 patients, wherein we took about CT scans of 150 patients of the whole femur, and we tried to superimpose a nail onto these femurs. And we found out that the radius of curvature that these patients had was much less in our patients compared to much more in the Western population. And we concluded that most nails which have a radius of curvature of more than 1300 in the Western culture, our patients need implants with a smaller radius of curvature because our bones are more bowed, so that the nail doesn't impinge on the anterior part of the femur. And we now tend to use nails which have a closer radius of curvature to our normal population, which is close to 1100 millimeters. Coming to arthroplasties, Dr. Malhotra has done a lot for us. He has been the guiding force for us for this management of multidisciplinary approach, starting off orthogeriatric ward and orthogeriatric beds in our wards. And he is a doyen of arthroplasty in India. So with him, we have started using larger and larger femoral heads when we are doing total hip replacements, which gives us a very higher jump distance, making these total hips very stable. Now, the chance of dislocation after having this total hip is decreased drastically. And we have started using dual mobility cups in these patients, which give all the more stability, making the chances of dislocation less and less. And Malhotra sir was the first surgeon in AIIMS to ever do a direct anterior approach. And now most of our patients having a neck femur fracture at this age are getting bipolars or total hip replacements done by the anterior approach, wherein the blood loss, the perioperative stay, the amount of pain has decreased to such an extent that most patients can be admitted the same day, and after surgery can be mobilized and even discharged the same day amongst this pandemic, when we want to cut short on the admission of these patients. Coming to a few case examples, 65-year-old female having a slip and fall at home, having pain, swelling, ecchymosis of the hip, diabetes, hypertension, hypothyroid. This is something that this patient has, but this is something which is present very commonly in all these patients in our age group, and this is something that the whole team understands. So now the aim is to get these patients to surgery as early as possible. our geriatricians, the anesthetists, the critical care team, everyone understands this concept. So rather than making a patient perfectly fit before a surgery and trying to lose the patient before that, now we try to make the patient go to the OT as early as possible, taking care of these problems to the maximum possible extent, but not delaying the time to OT. And this patient underwent a long proximal femur nail, and that's the patient walking. This is a video taken at the time of suture removal in the outpatient department. But these patients are even mobilized on the same day they are operated, most of the time, if not the very next day. Another example of a 80-year-old female having the same history of slip and fall at home that Nishank has already explained. Most of these patients, 80 to 90% of these patients, have a history of only slip and fall because these are very osteoporotic to start off with. She was a hypertensive since last 10 years. She underwent a short proximal femoral nail. Most of these surgeries will last anyways 5 to 10 minutes. And by the end of the day, these fractures heal really fast, really soon. This is a 3-month follow-up. And this is the same patient, 80-year-old, mobilizing at home. It is difficult to even determine which of the sides has been operated. Another case of a 66-year-old male having a history and slip and fall at home. One may miss these small fractures here, but these are all fragility fractures. This is a neck femur fracture. He was a newly diagnosed hypertensive, on 5 milligram once a day. That's the CT scan to confirm the diagnosis. And this patient underwent a hybrid total hip replacement because he was fairly active for his age, and the patient was mobilized the same day after this surgery. Another case of a 81-year-old female. She just had a fall from bed and sustained a neck of femur fracture. She had a history of affective disorder with cognitive impairment on a lot of medicines, and was able to ambulate herself before the trauma. And those are our preoperative x-rays. Just look at the amount of osteoporosis that this patient had. She did not just have a neck femur fracture, but it had an intertrochanteric extension as well. So this is a variety where both neck femur and intertrochanteric come into the picture. And these are the patients that need to be mobilized ASAP. And even though this is a slightly more challenging replacement, but this was done, and the patient was mobilized the very same day after this surgery. And this is the follow-up of the same patient. And this is this patient mobilized within 1 week of surgery. So the aim of post-operative rehabilitation is immediate full weight bearing. Whatever we do in the operation theater, whatever we do, at the end of the day, if we feel that what we are doing is not going to allow the patient to weight bear the very same day or the next day, then we do not come out of the OT and do something so that the patient can walk the very next day, because that is the goal that we need to achieve. Obviously, with the slight amount of pain and the hip fracture, these patients may have a slightly different gait for the first few weeks before the fracture unites, and hence we encourage the use of a walker for the first 3 to 4 weeks, after which the patients can take the walker off and to prevent but they are taught to prevent a secondary fall. And the physiotherapists not just visit these patients once a day, but many of our physiotherapists would visit them twice a day to ensure that these patients are mobilized well, because the whole aim of the management, surgical management and the medical management, is to make them moving as soon as possible. And this continues even on Sundays. And we do balance training and fall prevention exercises for these patients as well, because there is 2 times the risk of falling again after hip fracture, which can result either in a peri-implant fracture on the same side or leading to a corresponding fracture on the opposite side as well. And 50% patients report fear of fall after having one such fracture. So now I would request Dr. Nishank to come in and continue the presentation.
So if there is one point which we want everybody to take home in this presentation, it is that treating a hip fracture is not the same as fixing a hip fracture. And it is important to understand that hip fracture is not a disease in itself. It is in fact a warning sign about the more serious condition of osteoporosis that the patient is suffering from. There are some hard facts to prove this. Patients with a hip fracture are twice as likely to suffer a subsequent fragility fracture, and more than 50% patients do in fact have a history of prior fragility fracture that was missed and left unaddressed. And if at all it would have been addressed at this first instance, that hip fracture might not have occurred in the first place. A mixed methods observational study done in Delhi itself brought out some tantalizing facts. 80% patients with fragility hip fracture are never offered screening or treatment for osteoporosis, and less than 10% patients with fragility hip fracture receive a formal fall assessment or balance training. So, with regards to the evolution of treatment at JPNATC, we would like to term the implementation of FLS, which stands for a fracture liaison service, as the watershed movement. A watershed moment which has changed the course of treatment at our institute. A fracture liaison service is a coordinated care model to guide the patient through osteoporosis management after a fragility fracture to help prevent future fractures. So before the implementation of FLS, the evaluation and treatment of fragility fractures were a part of routine OPD. There was no dedicated registry or personnel, and we observed that there were high dropout rates, as much as 80% with respect to these patients. Again, there were no records of investigations done or treatment given, and it became impossible to analyze and draw conclusions regarding how our patients were doing. The International Osteoporosis Foundation has propagated the establishment of fracture liaison services across the world. As you can see in this map, most developed countries in Europe and North America have comprehensively adopted FLS in their own setups. But this has not been implemented so far in India, and only 2 hospitals in Delhi have a functioning FLS at their institutes, one of which is AIIMS. So fracture liaison service acts as a one-stop shop as far as preventing a second fracture in patients with a fragility hip fracture is concerned. And the benefits to the healthcare system are many. It results in fewer refractures, fewer secondary care admissions, and fewer operations. The FLS model is built around a dedicated nurse coordinator following a standardized investigation protocol, meticulous record keeping, and raising public health awareness by various means, all with the eventual outcome, which is preventing secondary fractures in these patients. Hip fracture patients sit right atop right on top of the priority list as far as stepwise implementation based on the size of impact is concerned. All the evidence suggests that FLS works, and in fact we can even go as far as to say that FLS is the only thing that works as far as prevention of a second fracture in patients who sustain a fragility fracture of the hip is concerned. Our experience with FLS, which was the first instance in which it was adopted in India, this led to a higher rate of diagnosis and treatment and a lower rate of attrition and loss of follow-up. And it also provided real-time data for epidemiological and research purposes. We have fragility fracture clinics every week at both in the main building and at trauma center. A functional fracture liaison service reduces the burden of secondary fragility fractures and integrates a multidisciplinary approach in itself, and finally leads to a uniformity in treatment protocol. The Fragility Fracture Network India was established in 2015, and Professor Malhotra was one of the founding members of this body. This was set up with the aim of improving the management of elderly people with fragility fractures through evidence-based care in India, and it brings together people from various disciplines who are involved in the management of fragility fractures. We never have to look beyond the head of our department and the chief of trauma center, Professor Rajesh Malhotra, for inspiration. He's a towering authority in this field. He's the secretary and founder member of Fragility Fracture Network India and the founder member of Asia Pacific Osteoporosis and Fragility Fracture Society. He has also been involved in the design of a special hip protector device for prevention of osteoporotic hip fracture in elderly. He is a member of the prestigious Global Task Force of American Society for Bone and Mineral Research for secondary fracture prevention, and this has given some definitive guidelines on this topic. He is also a member of expert group of ICMR Task Force on Osteoporosis. He has several widely cited publications and book chapters to his name. And under his stewardship, FFN India and the Department of Orthopedics also runs several initiatives aimed at promoting public awareness with respect to osteoporosis. We have balance training and several state-of-the-art equipment for balance training and fall prevention, as well as a state-of-the-art gait lab for conducting locomotion analysis in elderly people for therapeutic and research purposes. I now call upon Professor Vivek Trikha to share the achievements of JPNATC.
Thank you, Nishank. And just to summarize what we have been doing over the last 5 years, we have the great guidance from our chief as well as the infectious enthusiasm of our junior colleagues who have been helpful while implementing this major task which we have had regarding the treatment of hip fractures. And as we all know, as a team effort, JPNATC has always been battle ready. Come whatever be the problems, JPNATC has always stood ahead and in the forefront of AIIMS. We have been treating 250 to 300 hip fractures, usually out of which 200 of them have been in elderly patients. As you have seen over the last 40 minutes, we have shown you the various modern implants, the various protocols, and the most important thing, the holistic multidisciplinary team effort, which has been instrumental in making sure that the surgeries which were done for 60% of patients in the first 24 to 48 hours now can be done. 90% of the patients can be operated within 48 hours of their admission in our hospital, which I feel is a great achievement for the last 5 years. We have got a lot of research as well. This is our orthopedic team over the years under the guidance of Chief and all the people who have been instrumental among the orthopedics, and not to forget the senior residents and the junior residents, besides the all other faculty and the specialities which have helped us in getting this thing done. Orthopedics, we have had publications. I'm just here to count out the laurels and the achievements while the work which has been done by other colleagues. It's the publications. We have nearly 15 publications or more than that over the fragility hip fractures. And these are not only the clinical outcomes which we have been showing. It's an observational cohort of why there is a delay in hip fractures, how we can improve on that. There have been some basic research on microRNA expressions in the osteoporotic patients. There has been, even with anesthesia people, of how echocardiography, whether it is really helpful in getting the things done or it is just delaying the surgery, as well as the clinical and the prospective randomized studies which we have been doing. There have been 3 completed theses, 2 of which were prospective randomized studies and which have been acclaimed in most of the papers which are there and published nowadays. Our aim was not only to establish it in our hospital, but also to impart this knowledge worldwide as well as in the national fora. We also organized the Geriatric Orthopedic Society annual conference in 2018, along with the first conference for the Fragility Fracture Network, which was established during those times, on our regular feature of current concepts in arthroplasty, which is our annual event of the Department of Orthopedics, which is also dealing with sort of elderly fracture, not fractures I would say, but arthroplasty, but considering other pathology which is there in the elderly patients. This was one of the major studies which was there, the hip attack, which was a multicentric randomized international controlled trial with the hip attack investigators, and which was done over 17 countries with nearly 70 centers. This was published in 2020 in Lancet, and our center was one of the major centers which was able to contribute a lot of patients and indices cases to this. and in which the comparison was done between 6 hours and 24 to 48 hours of surgery, which is the standard care of surgery. And this has been widely acclaimed and cited in most of the papers now, which are there for the hip fracture treatment and standard care. There have been not only the research projects from intramural, which we have been doing, but also extramural projects, and there has been a lot of funding which has been given for the papers, the hip attack, then regarding the artificial intelligence and how it can help us, which is an ongoing project right now, along by Professor Vijay Sharma, along with yoga, which whether it can help us, and the role of yoga also has been there. And a lot of funding has been brought to this institute from the various other centers which are able to provide and guide us for the important research in this major topic. One of the major things which I would say is the orthogeriatric thing, the multi and the coming together of multiple disciplines, make a special unit for treatment of these fractures, which was done, I think, for the first time in Indian or in South, at least in Indian subcontinent for that matter. And we have had, under the guidance of Dr. Malhotra, who when he joined, he said, immediately we had a specific number of patients and the beds which were allotted to take care of these geriatric patients, and where the geriatricians and the geriatric department also was quite helpful, and they have been coming regularly and taking care of the pre and the post hospital care for these elderly patients. And if I can say, our job has become easier to just be in the perioperative, intraoperative period and do the surgery, while the rest are being taken care by our medical friends who are very competent in doing this and are the right persons actually. And this is what is called as combination of the best specialties and the best expertise in taking care of the patient's care, which is the foremost for us. The follow-ups in the fragility fracture and the fracture license clinics and the services which have been started, they are the new things which have been doing in the country at present. I think to end it, what is the way forward? We have been doing the capacity building, which has been done by our center in this treatment of these elderly hip fractures, by educating health professionals, up-to-date medical guidelines, and also quality improvement, which has been done by taking care of the fracture license service, having a multidisciplinary effort by all the specialties involved, and improving the surgical protocols of managing them within the first 24 to 48 hours. What now we need to do is build upon this data and the information and the things which we have learned over the last 5 to 10 years in our major center for the hip fractures to be implemented all over the country as a national policy. And I think that our people who are in the higher chairs and authority positions, including our chief, Dr. Malhotra, as well as the people in other specialities, will be able to guide us for implementing these policies in the national fora as well. Because most of the people, as we remember, next 20 years, our population of elderly hip fractures is going to increase to nearly 30% of that. And we'll have to focus these policies even in rural areas. I think that finishes and completes. I think I would like now to invite Sir, Dr. Chief, Dr. Rajesh Malhotra, sir, for his final comments and remarks.
Thank you. We should have a few questions, I hope. I just would like to summarize. Hip fracture scale, the number is on the rise. The number has to be tackled, and early treatment is the key. The surgical treatment is the key. The orthogeriatric co-care is the standard all over the world, as is the surgery within 36 to 48 hours, for which we are grateful to our anesthetist friends who have made it possible. You have seen how we have been able to achieve those targets. We can't do anything about the delayed presentation to the hospital, but once patient comes to the hospital, we are in a really fast track mode to put the patient back on the feet, and we tell the attendants that the patient may still die in spite of best treatment because of the other problems. The fracture license service is important because it's a fracture cascade. One fracture leads to multiple other fractures, and that's why if we don't intervene in terms of secondary prevention of fractures, then we are really missing in our duty. And lastly, we concentrate on their balance and fall prevention, because it is said, break the fall, not the bone. Thank you very much for a patient hearing, and I would like to invite you for any questions. My team here and myself will be happy to answer the question. We'll have 1 minute. We are very happy to answer any questions if there are some. But then I would like to congratulate my team at the Jayaprakash Narayan Apex Trauma Center. They have really worked as a team, come together to meet this challenge of managing this menace. And the importance is not lost on anyone. This is not something on which we would ever have an argument with the anesthetists. Everybody knows that this has to be done. This is not an elective surgery. This is a life-saving surgery. This is one of the conditions in orthopedics which is life-threatening. So it has to be managed accordingly. And we get all the help from the geriatrics, from sometimes if required cardiologists, all our colleagues from other specialty who help us put those patients back on their feet. Well, if there are no questions, I once again thank everyone who has attended and my team. Thank you very much. Have a nice evening.